Just briefly, today our topic is not so long, but just I wanted to be to make it like refreshing lecture. It will not take, I think, 15 to 20 minutes, but still very important topic in the head and neck imaging. Even not in your for the exam. It is in the exam. Crucially, you will have at least in the 2A one question from this lecture, at least one question. On the other hand, in the clinical, you it is very rich of questions. You may meet all the head and neck exam, the part of the head and neck in the FRCR final exam from this region. Okay, either the long or the viva, long and the viva from this region, and what is the syndromes related to this region. Okay, so it is the salivary gland. The salivary gland. Okay. First, we have the major salivary glands. The major salivary glands. I'm not speaking about the minor ones. So when I say the major one, so the parotid, submandibular, and to somehow the sublingual glands. It is the anatomy of the parotid gland, and the parotid gland is a very important structure. Not because it's a function. No, because the structures related either by passing through the parotid gland, in the vicinity of the parotid gland, the vascular structures, the nerves, the termination of the facial nerves, the connections between the facial nerve and with the even the trigeminal nerve come nearby to this region, the region of the perineural spread. So the parotid gland is very important as anatomical structure. Beside that, the parotid gland has lymphatic component, so it can be involved in the lymphoma. Okay, so the parotid gland is not important itself as the importance of the structures related to it, the nerve, the veins, the lymphoid tissue. So it is very important, the most important salivary gland in the most important topics related and subtopics related to the salivary gland imaging are related mainly to the parotid gland. Okay, it is the anatomy, the masseter. When you go up outside masseter, inside temporalis, and here it is the tragoid muscles. Okay, and here is tension duct, and sometimes you will find this common variant to have accessory parotid gland, so you don't make wedding party when you find accessory parotid gland in this MR brain. It is something, just if you like to mention it, don't highlight it, because some, especially two things related to the parotid, which makes problem in the reporting, not for the exam, in the normal reporting, because you find something lymph node, intraparotid lymph node, you say small intraparotid lymph node, so they will investigate why does this need further investigation or like that, and also the accessory parotid. Okay, so the parotid imaging now should start with the ultrasound. When you are suspicious about anything related to the parotid gland, the first investigation of choice is the ultrasound. Okay, so the ultrasound, when you find incidental finding, the next step is the ultrasound. Keep this in your mind in the exam. If you find an incidental finding in the CT, what is the next step? Ultrasound. Okay, and biopsy, because the head and neck sonographers or the head and neck consultants, usually if they find something in the same session, they take a consent from the patient and take a biopsy from it, if they are sure that the patient is not on blood thinner, especially for the true cuts. So the ultrasound for the neck is crucial, and for the parotid gland is the first line of investigation, okay, of the radiological investigation. We have the superficial lobe and the deep lobe, and here the posterior belly of the digastric muscle. Okay, there are anterior belly. It is the deep lobe. You see here the sublingual gland, the hyoglossus, and the mylohyoid muscles between both of them. And here is the common structure which can come very common in the exam, the ranula, which is related to obstruction of the sublingual ducts. Okay, this brief anatomy. And here is the submandibular gland, very important structure, especially when there are obstructing stones. The obstructing stones in the duct of the submandibular gland is more liable to have stones inside it, because the course is a bit tricky compared to the direct course of the parotid gland. Here, in submandibular, it has to go a bit upwards, mildly upward, before going to the mouth floor. So the incidence of stones in the submandibular gland is higher compared to the parotid glands, and it is affected by the alcohol. Okay, so we have here the hyoglossus and the duct coming between the hyoglossus and the mylohyoid muscles. Okay, let's start with the lesions. This is the most important pathology in the salivary glands, because I don't like to distract you. You don't need more than these topics to merge well through the salivary gland in the exam. First, for the parotid gland is Wharton tumor. Oh, sorry, it's pleomorphic adenoma, then Wharton tumor. The malignancy, mucoepidermoid and adenoid cystic. Adenoid cystic is more common. And the nodal mets, we spoke previously about the presence of lymphoid tissue, sialadenitis, and the Sjogren syndrome. Pleomorphic adenoma is the most common benign tumor of the salivary gland, of the parotid gland, and in the pleomorphic adenoma, it is the most common tumor. Involve the deep and superficial components. Variable enhancement. T2 hyperintensity. The EDC value, high EDC value, so it is not pathological. When you see the pathological EDC value is when it is low EDC value. The problem is a compression. The compression, and also on the other hand, the ENT or the head and neck consultants don't like, generally, they don't wait until something wrong develop in the head and neck. Most of them will take it out. The rapid growth or newly developed pain or newly developed facial paralysis is the alarming sign of newly developed neoplastic activity. The newly developed hypointensity signal suggests a malignancy. The newly developed low EDC value suggests a malignancy. So, pleomorphic adenoma is a benign tumor. It's the most common tumor of the parotid gland. When you say pleomorphic adenoma of the parotid gland, remember T2 hyperintense. T2 hyperintense. And the variable enhancement, not low EDC value. Malignant if rapid increase of the size, newly developed paralysis, facial paralysis or pain, and newly developed intrasubstance, hypointense T2 signal. Okay? Multifocality, bit rare. And because you are beside the facial nerve component, so these very sensitive to the development of malignancy. Okay. Next is the Wharton tumor. Wharton tumor still benign. Remember, in Wharton tumor, it is hyperintense, but not like the hyperintensity of pleomorphic adenoma. Okay, this spherical, ovoid, and have smooth surface. The size normally from 2 to 4 centimeter. Anything benign more than 5 centimeter, you have to raise the alarm about it. This is for your career. I'm not speaking about the exam. When you find something more than 5 centimeter, even lipome, you have to raise a concern about it. Even with benign features, you have to raise a concern about it. The size is something is not, the size have a limit all the time. You speak about benign nature and suggest the benign pathology. But if the size is, if 5 or more than 5 centimeter for any lesion, kindly raise a concern about the possibility of neoplastic nature, okay? Which could not be obvious. It can involve the inferior wall of the parotid gland, smooth margin, and in T1 and T2, it is the most common benign parotid tumor. 90% of the patients smoke, and the mean age is 60 years. The next tumor, it is not common like the adenoid cystic. Adenoid cystic should come before the mucoepidermoid carcinoma, but this is because I got this from one of the papers, so I have to make it in the beginning. But if I'm the author, I would make adenoid cystic in the beginning. Okay, why? Adenoid cystic is the most common. You will meet in the exam one of the question asking about the development of perineural spread. Both of them have high instance of the perineural spread. Why the perineural spread is something important in the reports, and you have to give a comment on that, and it is very highly uprising in the NHS and in the FRCR exam, because the perineural spread can change completely the management plan. It can make your management plan operative, or can make it only radiotherapy and chemotherapy. If you tell the clinician that there is a possibility of perineural spread, this means that this patient may not have an operation. This will be sent to radiotherapy or chemotherapy. You understand that how much it is uprising this day. So it is very important to consider this point, especially in the FRCR2A and in the 2B, to know well that when this ring in your mind, pathology in the parotid gland, and there is a possibility of malignancy by the history of paralysis, relative hyper low signal within the or heterogeneous T2 signal, or low ADC value. This means that this alarming sign of malignancy. Tell the examiner, for the next step, I would like to check for perineural spread. What is the easiest sign? The easiest sign to rule out perineural spread? The anatomy. Pterygopalatine fossa. Check here in the this region, and this region, and the muscles. This region, and this region, and the muscles. If you find the muscle edema, unilateral muscle edema with parotid lesion, perineural spread. Okay, this is perineural spread. So mucoepidermoid and the adenoid cystic, like the relation between the inguinal hernia and the femoral hernia. The inguinal hernia will be like the adenoid cystic carcinoma, has high incidence, more common compared to the femoral hernia. But the femoral hernia itself has higher possibility to strangulate and to obstruct. This is the same for the mucoepidermoid. The mucoepidermoid has higher incidence of higher possibility to develop perineural spread. But because the adenoid cystic carcinoma is more common compared to the mucoepidermoid, so there is a high possibility. Generally, there is higher instance of perineural spread. In the exam, if you will find both of them, and it choose adenoid cystic carcinoma, like choosing the inguinal hernia for the possibility of obstruction. This is the most common primary malignancy, but for me, it is adenoid cystic, not mucoepidermoid. This low grade, well circumscribed cystic changes, heterogeneous with heterogeneous enhancement, indistinguishable from benign lesion. This could be the high grade is infiltrative in appearance and the appear T2. The low grade can appear as high T2 signal. The high grade can appear as low T2 signal. It looks ill-defined in the margin. T1 is more sensitive for lesion detection. Normally, it enhances and always check for stylomastoid foramen for the lymph nodes and for the perineal spread.